So I'll try to wake you up, okay, and get you going for my successor so that you are awake and you are interested in what they are talking. So humans are power hungry. Okay, I know this is not the topic of my talk, but they are power hungry, and power has evolved from being physical power when the man was primitive to the economic power and now to the power of information. And how this is related to my talk, I'll come to it. And this is a suggested reading on power shift, and the power has shifted from muscle to money to mind. It was always the mind, in fact, but yes, now it is more obvious. So this is Amrita Hospital, and I am an employee of Amma, and as Dr. Khalikur has rightly said. So, where liquid biopsy is a breakthrough discovery. So, in around 1900, X-ray was first discovered, and the person who discovered it got a Nobel Prize. So, that time, X-ray was able to pick up the volume of tumor when there were 10 to 9 cells. And then there was another discovery of CT scan, for which again New York shared the Nobel Prize, and then the resolution of the machine could go even better, better to 10 raised to power 7. And then now this liquid biopsy or ctDNA is when the resolution of has gone to even 2 lower. That is 10 raised to power 5, but there are no Nobel Prizes. In fact, this was already picked up, this presence of circulating DNA was already picked up in 1948. It is only recently that we have learned the utility of this kind of technology. And with this power punch, and why I'm saying liquid biopsy, because liquid biopsy is offering more information. And more information means better choices, and better choices means better results. And better results can mean anything from money to power or whatever you can think of. Okay, so what is ctDNA? So this is tumor DNA. These all cells are destined to die, and when they die, they necrose, the apoptosis occurs, and these are fragments. Even the normal cells die. So these are fragments which are wrapped around the nucleosomes, and that is why there are around 170 base pairs. And since there are these tiny, teeny fragments in a pool of lot of normal cell-free DNA. Okay, so you will need a very sensitive technology to pick it up. So that is one catch. Okay, everything or every technology cannot pick this up. So of course, there's tissue biopsy and liquid biopsy. So one thing is very clear: it is not a substitute for tissue biopsy. This is only offering you more information. So yes, at times you may use it, but no, it is not a substitute. It has certain advantages over tissue biopsy and certain disadvantages. One, the heterogeneity, which is not covered in your tissue biopsy because it is taken just from a small areas, are covered in this liquid biopsy. That is one big advantage. And but there are certain other disadvantages, like the DNA yield is variable, so it will depend on a lot of factors. You might require special tubes, and the variant allele frequency can vary. It may not actually give you the true picture always. And the analytical sensitivity of your testing modality, as already mentioned, has to be high, and of course, the cost. That is, so there are various approaches for picking up circulating tumor DNA. So these are targeted approaches, which are like PCR-based approaches. So TCRs can be a routine PCRs. Some of your instruments like Cobas and TerraScreen have got FDA approval also, but there are certain more sensitive technologies like the digital PCR. So these can be used, and there are a limitation that they can only look at few genes or few variants at a time. But then there is an advantage in these digital PCR technologies. So one, of course, is the sensitivity. And the second is they give you absolute number of copies. So that's a big advantages which even the NGS doesn't offer. In fact, if you need to validate the variant allele frequency of your NGS, you will need a droplet digital or a digital technology. for that. So that is a big advantage. It gives you absolute. If you all, I think you all must be knowing PCR, it is always a comparative thing. So you're always comparing with a housekeeping gene or something, but here is something which can give you the absolute number. So that's a big advantages. And then there is an untargeted approach, of course, looking at the multiple genes together. So that is based on NGS, and you have various technology, and the whole day we've been talking about it. So with NGS platforms, I'll be rushing with it. One, I realize that it's too much, and second, I have a flight. That's the more important reason. Okay, so there are various consideration for NGS platforms. Of course, the essay, the commercial essay, your design, the validation, the quality, of detection. That's very, very important in a liquid biopsy assay, and sensitivity, specificity, bioinformatics, and reporting and cost. Okay, so what is important in a liquid biopsy NGS assay? I told you about the PCR-based assays, but about the NGS assay, the technology has to have a UNI, that is a unique molecular identifier. So you can have two unique molecular identifier at the sense and the anti-strand strand, and then you form families, and then you remove the duplicate PCR errors and sequencing errors. I hope there may be people who have not understood what I've said, but what I'm trying to say is this is the technology which tries to make you pick up the things like which makes it oversensitive, the word I use. So this is what we are trying to do using this UMI based technology. So you should, when you're asking for a panel and just panel, look, is that the UMI is attached on both the ends or one end? So those kind of technicalities should be known if you're ordering or if you're planning to do this. Then most of them are DNA based, and if you're looking at fusions, these are also DNA based. So you need to know the entire area and all your transcripts are covered. So that is one thing. And then there are certain cases like your exon 14 skipping mutation, which are splice mutations. So in your tissue biopsy, after picking them up, it's like you did at the RNA level, your exon 14 is missing, and you see if your fusion product of exon 13 and 15 is available. Biopsy, it might be that you're looking at all the splice site mutations and then calling it as an exon 14 skipping mutation. So these are the nitty-gritties which should be looked into. And then, of course, the very, very, very important, and this is variant allele frequency. This is a very tricky calculation. One, by definition, variant allele frequency is the amount of your mutant. It's a ratio divided by the total amount of DNA, cell-free DNA present, which is the mutant as well as the wild. But the wild can vary a lot based on maybe if somebody had a trauma or inflammation or some physical activity, your wild component will increase, and that will vary your ratio. And tomorrow we are talking of monitoring based on your liquid biopsy, and this thing can be manipulated by change in the value. So how will you be sure about that? So that's a big problem which actually most of the people are not talking. But then there is a solution to that. There are some endogenous targets which are not common to not seen in the humans, and which are introduced into your cell-free DNA, and which will act like your comparison for your way. Instead of using the wild type, you will use them. So this is coming, and since we will have a lot of monitoring, in fact, all your tumors will have a cell-free based monitoring eventually. So this is starting with lung, of course, but it will happen to all your tumors. And these nitty-gritties should be known to the individual who is going to do them, because most of us don't even think about them. So then, of course, clonal hematopoiesis, it's been talked about. So you are going to look at plasma, but then you need to know that there will be contamination by the WBCs, and aging is also a reality for everybody and for the WBCs also. And as they age, they have these mutations which are not coming from the tumor, but which are coming from the WBCs, and you need to take into account. And ideally, if money is not a constraint, then you should be doing two sequencing, one for the plasma and the second for the Buffy code, and then subtracting out the clonal hematopoiesis, and then just giving out the mutations which are present in your plasma. But we live in a real world. this doesn't happen. At least you be aware of these mutations. Some of my colleagues have already mentioned them, but yes, they could be in TP53, KRAS, even your KRAS 12C, which has a drug, could have. Even a BRCA can be present as a clonal hematopoiesis mutation. So you need to be aware of these things. And then, of course, since it's plasma, and germline mutations are present in all cells of the body, so these could be contaminating your plasma sample, contaminating, or maybe it is always present. Say, for example, T790M, which is a resistant mutation in your lung cancer EGFR mutant patients. So there is a very, very tiny chance that there are people who have this as a germline mutation. So there, the variant allele frequency, of course, will be high, and you may need some other modalities to confirm. And these patients also have lung cancer. So that is there. And there are other mutations also. That's just one example. You need to be aware. So awareness will proceed, like you look for it if you're aware about it. Then, of course, coming to the main topic. The main topic starts from here, the applications of cell-free DNA. So, of course, I told you that lung is leading the bandwagon. And then we have in lung, we have many bodies, the ESCO, everything. But in lung, we have the big granddaddy, that is the ISLC. So that has put up a paper, it's a consensus thing. So they have suggested that there are multiple approaches of combining your tissue as well as liquid biopsy. There is approach of plasma first, then there is a sequential approach. You do the plasma and then your tissue, and then there is a complementary approach. So what the whole world, especially the Western world, because we are mostly following them, right? That's bad, but yes, it is happening like that. But and there is a lot of sense in that also. The world is falling for the complementary approach, that is doing the tissue as well as the liquid biopsy, because again, it is more information, better decisions and better results. Okay. So then what is the concordance between tissue biopsy and liquid biopsy? This is for lung. So the concordance is superb. It's sensitivity of around 80% and specificity is around 90 to practically 100%. If you found a mutation and it is there, okay. So, but sensitivity, all cases, you may not find mutation in the liquid biopsy. We have multiple studies, they're trying to say the same thing. And this is my personal experience. So we have done in my previous institution, around 100 cases, we again found a sensitivity of 80% and a specificity of around 100%. So this is right from the horse's mouth, so you can have it. And then this is a Canadian study, value study, where they tried not in this combined approach, they try to calculate the financial impact. Okay. And in lung cancer, 30% of your patients don't actually get the tissue biopsy. So you need to do it. And then they calculated the financial impact. In fact, it was on the government, because there the government is paying for all the testing. It was better when you combine both of them, because 30% of the tissue is rejected. So that's again there. It's only we have to accept that kind of thing. Then, of course, the bottom line is synergy. Combine tissue and liquid biopsy smartly wherever you can, depending on your finances. If you don't have, you can just use a single gene. If you have the finances, do it. More information, more better decisions. So then, of course, monitoring, and again, it was leading the bandwagon. And this is a study which was recently presented in the ISLC 2022, and they have shown that there are three groups of patients. One who have a tissue confirmed EGFR mutant, and the liquid biopsy is also EGFR mutant. Okay, and then there is another group which has tissue EGFR mutant, but liquid biopsy is negative. So the patients who did not have liquid biopsy positive initially, and also upon treatment, they were negative. These patients have performed the best compared to the patients who were positive initially and that they became negative. These were the second one. And the patients who were positive and also remained positive after 3 weeks of treatment were the ones who performed worst. The duration of this monitoring is really actually not clear right now, because there are various studies. Some are monitoring at 3 weeks, some are monitoring at 6 weeks, maybe depending on their budget, but definitely this is in here. And this is only lung cancer, which is just leading the game. it will follow for the other cancer because there are promising results. And what we talked was for EGFR mutant, but also for ALK and translocated cancer, the same thing is true. And of course, if you are doing the NGS kind of liquid biopsy, you may have certain co-mutation like your TP53, and patients who are EGFR mutant and also have TP53 are likely to perform worse compared to the ones who just have EGFR mutations. And then not only your blood or your plasma sample, the other samples, other bodily fluids like your CSF are wonderful resources, and especially in conditions. This is a study again published in ISLC, where the patients with increased concentration of cell-free tumor DNA in CSF at 8 weeks had a significantly shorter intracranial progression-free survival. So you can see it is prognosticating. And this is my own personal experience on around 22 patients, in patients who were suspected to have leptomeningeal diseases, but they were not confirmed. Your MRI was not giving a picture, but your CSF was positive, and that did help the clinician to decide the next mode of treatment. And they knew that these patients were going to perform worse. And that's what I want to tell you, not towards your CSF. CSF, in fact, is a very rich resource of your cell-free DNA, can be used smartly in your different clinical situations. Then this is just to show that resistant mechanism. I think this is known to most of us, that the EGFR mutant and upon resistance, around 50% of them have T790M mutation. But we're just talking of T790M because there is a drug for it, but there are other mutations also. In fact, 40% of them also have meta amplifications. And in fact, I have seen a case, EGFR mutant, who turned into ALK translocated. So if you are doing the NGS kind of liquid biopsy, you may have many surprises. And in fact, maybe I'll show you, this is in my paper, where we have shared experience of 400 cases with liquid biopsy and tissue biopsy, and this is what we found. So you have to use smartly. It could be picked up by the liquid biopsy or tissue biopsy, or at times you may not be able to do tissue biopsy. Okay, so this is the paper I was talking about. Then basically this is like there are people who are doing hematology here. This is to make you understand, or maybe I think you already understood. So just to give you simile, that it is BCR abilization of the solid tumor. So this is what is happening to the solid tumor. Only the liquid malignancies don't have that artifact of FFPs. I think they lead the thing, but the solid ones are also catching up. Okay, so this is just another study to show that the ctDNA in resistance or in progression comes far earlier than the imaging thing. But we still don't have the answer. Do we actually change the treatment just based on the progression seen on liquid biopsy compared to the imaging? We don't have the answers, but maybe soon we will have, because we are seeing the patient who had ctDNA actually eventually progressed on radiology. So this is another thing which there's a trial going on, the patients whose ctDNA disappeared. So till now we were not able to stop the treatment, just like your CML. So they have done trials to stop the treatment based on the ctDNA. So offering a drug holiday, so that is less toxicity and less, not only to the body, but also obviously less financial toxicity. So that can be offered. So this is newer, and though these are not in the guidelines right now, but they are showing promising results. Then coming to colorectal cancer, I know I have 5 minutes, but so in colorectal cancer, liquid biopsy can be used. So most of around 50% of the patients have metastatic disease, and these patients who have these KRAS and RAS wild type, they are offered anti-EGFR antibodies like cetuximab or pentuximab. Okay, and this offers a 30-month overall survival advantage. So that's a huge advantage, but this is only offered in patients who are KRAS wild type. But as the patient is on these treatments, subsequently the resistance develop. And if you monitor on liquid biopsy, what happens is you find the KRAS clones coming up. So when the KRAS clones mutations comes up, these drugs, these antibodies don't work. Okay, so that's another why they don't work. We can talk about it, but about liquid biopsies, so you can monitor that just by liquid biopsy and offer the patient again a drug holiday. And when these subclones of KRAS disappear, you can again continue the patient on anti-EGFR therapy. So that's a big advantage that can be done. And again, the concordance in colon cancer is around 93%. That's big. And another big thing where I feel this will come is in stage 2 colon cancer. In stage 2 colon cancer, the modality of treatment is surgery, and 80% of them do very well just on surgery and they don't need chemotherapy. But there are these 20% people who will need chemotherapy. So how do you identify those 20% of patients? And those 20% of patients are identified by liquid biopsy. If they have the mutations present, then these are the candidates who should be offered liquid biopsy. And there are many studies, you can see the difference, the survival difference. You can see that straight line that's like, and the people who have ctDNA, you can see their survival, progression-free survival is so bad, and the hazard ratio is 13. So my God, that's a big hazard ratio. So that is the advantage in colon cancer, and this is going to be, it's already there if you can do it, but yes, it will be written in the guidelines very soon. So about breast cancer, this is PIK3 mutation, which is then tested in patients who are ER positive and who have progressed, and they are offered alpeslib. And this can be tested on a new biopsy as well as on liquid biopsy. So that option is also there. So I think some people may not know it. So that is in the recommendation in the NCCN guidelines. Then another area where liquid biopsy is there in the guidelines is in the prostate cancer. In metastatic prostate cancer, there are 23% patients who have homologous repair gene defects. So this can be somatic and germline. And the guidelines say you could do a germline testing or a tissue testing or a liquid biopsy testing. But personally, if you ask me, I will say do a germline and a tissue testing. Don't do a liquid biopsy testing. But it is there in the guidelines. Okay. So guidelines are not gospel truth. You have to use your common sense and personal experience. So, but it is there in the guidelines. So that's what. And again, about the agnostic marker. So for immunotherapy is big, and we have two, in fact, agnostic markers in immunotherapy, that is tumor mutation burden and microsatellite instability. And these are till now only be given based on the tissue testing, but there is a very good concordance with the liquid biopsy. You can see it, but only thing is you will need more DNA compared to your conventional testing. Of course, it's right now not in the guidelines, but if you are venturing into it, that area where the patient doesn't have an option of treatment, then here it is, and you cannot go for a second biopsy or there's something of that sort. So here there is something which can guide you for further treatment. Okay, the future, of course, is prime time for blood first or a complementary approach and immunotherapy, tumor mutation burden, MSI, and pseudo progression in immunotherapy, which is a big problem, can be looked at in liquid biopsy, and you can know that it's a true progression or pseudo progression. And other members of liquid biopsy, like your exosomes and tumor educated platelets and circulating tumor cells, are also in pipeline in the future. And this is the icing on the cake. Early cancer screening. So for early cancer screening, what we have are few protein-based biomarker like your CA, PSA, although. But there is this whole low-pass whole exome sequencing as well as copy number changes and fragmentomics. Based on that, you can predict, and the sensitivity of screening test here in stage 1, my dears, I am talking about stage 1, is around 84%, and around in stage 4 is around 100%. A screening modality with that kind of sensitivity, and of course the specificity is good. So you can, so based on this, somebody who's absolutely normal, you can just look at this, and there's a lot of work going on this. So this is just one paper, 2019, but you can it's so all over if you just look at. So a person who's absolutely normal and just look at his blood sample and tell them he might be harboring a cancer in the liver. You can go and have a look there or do something. So things might be changing for the future. So with that, the future is bright. And thank you for the patience.